Just talk a little bit about what is cognition, how cognition might be impacted in the schizophrenia spectrum disorders. How does that actually play out in real life in some ways, and what is cognitive remediation training or cognitive remediation therapy itself. So cognition, sort of all of those domains of thinking, if we think about that as a big pie, we can pass those up in a number of different ways. And I think that I'll talk about some, but again, different researchers, experts sort of consider it in a number of different ways. So one of the domains is attention. And attention itself is an umbrella term, and there are lots of different subtypes of attention. So we can think about simple attention, just my ability to focus on something for a period of time. For instance, if I'm looking at a phone number or listening to what someone said, just kind of taking that information to be encoded into memory. The ability to hold that for a longer period of time is sometimes referred to as sustained attention. And then you can also have divided attention, which is my ability to sort of split my attention between different things. An example of that might be, for instance, if I was trying to drive and I need to switch my attention between what I'm seeing in front of me, what's in the rearview mirrors and the side mirrors, or sometimes also be trying to drive and have a conversation with someone at the same time. Memory can also be passed out in a number of different ways. So it can be divided into the verbal and the non-verbal domains. It can also be sometimes divided between what we call semantic memory and episodic memory. So semantic memory is our memory for factual information, and episodic memory is how we remember the events that have happened in our lives. So the stories, the narratives, our autobiographical memory, and so on. And working memory is sometimes considered a part of memory, and sometimes it's considered a part of the domain of what we would consider executive functions, or these higher level processes, which are involved with our ability to engage with the world and actually sort of plan and do things. And so the components of executive functioning might include planning and sequencing, as well as our ability to inhibit my urge to do something so that I can kind of pick what action I would like to engage in, as well as the initiation process itself to action. And so we can think about all of these as coming together in social functioning and in our everyday lives. And there are a couple of other components of cognition as well, which would include things like how my ability to take in visuospatial information and the speed with which I'm able to do that. So of course, the difficulties that can happen for someone who's struggling with cognitive challenges could happen in one of these domains, in multiple domains. It could also be sometimes in one of the in quotes low-level domains, which could then have a knock-on effect on our ability to do a number of other things. So of course, careful assessment to try to understand what is affected is a really important part of that process as well. And for the most part, if the data that's available for information processing is impaired by poor sensory processing or poor attention or poor encoding, that would then have an effect on all the other, like the executive functioning and so on. And even though most of the time when we are thinking about cognitive difficulties, the way most of us experience it or describe it is we say, oh, you know what, my memory is really poor, or I kind of can't remember what I need to do, or sometimes forget in the midst of things. But that difficulty can happen for a number of reasons itself. And separate to these domains of basic cognition, as we consider them, is also the area of social cognition, which is my ability to recognize emotions that other people might be having, or pick up on social cues and nonverbal cues, and to adjust my behavior appropriately for those different social contexts itself. So in schizophrenia and the schizophrenia spectrum disorders, there has been a lot of data which has found consistently that that these deficits are seen across most of the domains of cognition that we talked about. And this is data from a while ago. This is one of those classic studies now. And what you can see in the open squares is the means and the standard deviations for a group of people with the first episode of psychosis, and the filled black squares are for people who've had a diagnosis of schizophrenia for typically like over 5 years. And what we see is that the pattern of the difficulties is actually quite similar across both those groups, and that zero line across the top is the average for the normative samples, so a large group of people who have not had any psychiatric diagnoses itself. So we can see that the domains of particular weakness do include attention, memory, abstraction, flexibility, processing speed, and so on. And this is another paper which looked at the difficulties or the scores across a battery of cognitive tests with individuals with schizophrenia, as well as people with the diagnosis of bipolar disorder with psychosis or depression with psychosis, compared to a healthy non-psychiatric control group. And what we find is that the difficulties are present in all three groups to varying levels. So the bipolar group shows the least cognitive impairment, and the schizophrenia group shows the most cognitive impairment. What we find actually over and over is that the presence of the psychotic symptoms itself is associated with the cognitive difficulty. So when we compare it to people who have a diagnosis of bipolar disorder without psychosis, they tend to do a little bit better than the folks who show psychosis itself. And these difficulties, as you can imagine, in cognitive functioning are reliably found across the schizophrenia spectrum disorders, and they don't tend to correlate with the severity of the positive symptoms, so with things like delusions or hallucinations. But rather, they are a predictor of daily life functioning in domains including employment and independent living and quality of life. And so we sometimes use the acronym, which is the 5 Ps, and that's to say that these deficits are pervasive, they are persistent. So when people are taking antipsychotic medication, as the delusions and hallucinations subside, unfortunately, those cognitive deficits may not subside to the same extent that the hallucinations might, for example. And they present early, they progress fairly early, and then they tend to sort of plateau out, and they predict functional disability. Now, even though they don't improve as much as the positive symptoms do with medications, we do still very strongly advise people to stay on the medications, because they are, of course, worsen when there are fairly persistent positive or negative symptoms as well. So you can imagine if someone is struggling with hallucinations, they are going to have much greater difficulty paying attention to the things that are happening around or encoding meaningful information, because they're so preoccupied with their internal experiences and so distressed by it. And that would, of course, have a knock-on effect on most of the domains of cognition and their ability to function in the world. So this is sort of some fancy statistical modeling, which basically just shows that when we look at measures of different aspects of everyday functioning, so someone's ability to engage in a workplace environment, that domains of cognition, attention and working memory, processing speed, executive functioning, these are independently impacting it outside of the effect of negative symptoms, depression, and so on. And these impact their ability to function in the community by having an effect on social competence or functional competence, and as well as their ability to function in the workplace. So when we are having a reduced processing speed, what that means is that our the speed with which we can kind of process information that's coming in or respond to that information is a little bit slowed down. You can imagine how that would have a negative effect in a workplace environment. Poor attention or memory can have an effect in a workplace environment. Impaired ability to plan or inhibit or sequence things would have would cause challenges in a workplace setting, as well as more generally, you know, with independent living or with social functioning. And you know, it's important to recognize that these are not caused because there's damage to any particular area of the brain, but rather really to do with potentially with inefficiencies within the network. So this is a study that was done by some colleagues of ours and my collaborator here at UBC. And this is a study using a working memory paradigm. So what happens is you are shown these letters on your computer screen. So it could be 2, 4, 6, or 8 letters. And you spend time just trying to learn those letters. And then there's a delay. And then you're shown one of the letters and you're asked, was this one of the letters that you saw before? And what you can look at is what are the brain networks which are involved with the encoding, with holding that information in mind during that delay period and in responding. And what we find is that we don't really need to look at the details of this, but if we just look at these curves in the graph here, you'll notice that for the control group, so people without a diagnosis of schizophrenia, there is a steadily increasing level of brain activity, which is sort of going from the 2, 4, 6 to the 8 letters. And for the patients, you'll notice that that same curve in that same brain network, between 6 letters and 8 letters, there's sort of a ceiling effect that's happening. So what we find is that the patients are having activity in the same brain networks. The pattern of activity is actually similar, but they need to sort of use those networks to a much greater extent at a slightly lower load. And when that activation limit is achieved, then probably not able to sort of push beyond that. So that's sort of the point at which they fall off. So when we look at the really high memory loads, they're doing okay till about the 6 letters, but then struggling beyond of that. So what we took away from that is that this indicates sort of inefficient processing within these brain networks, and that if we can help with increasing the efficiency, that could then in turn have an effect on improving performance as well. So because these cognitive challenges do not respond to medication, we do need specialized interventions for that. And that's where cognitive remediation comes in. So cognitive remediation, this was the definition which was developed by the Cognitive Remediation Expert Working Group, which is an international group, including Dr. Chris Bowie from Queen's University. And it's an intervention that targets cognitive deficits across those domains that we'd spoken about, using learning principles with the goal of improving functional outcomes. And very much a part of that is that the effectiveness is enhanced when it's provided within a larger psychosocial rehabilitation context. So with opportunities to improve those everyday functioning. And initially, this was not something which was developed for psychosis per se, but was really developed to help improve outcomes following brain injuries or brain lesions, and also looked at as a way to try to prevent cognitive declines associated with aging, or to help to mitigate the effects of dementias. And there have been multiple approaches which have also been developed for the schizophrenia spectrum disorders, other severe mental illnesses, including OCD, ADHD, PTSD, and so on. And so there are a number of different types of cognitive interventions, and there are a lot of common principles that we will focus on. So typically, and we'll talk a little bit about the components. So it can be provided in a number of different ways, depending on what who the patient or the client is, what are the treatment goals, and so sometimes those could be paper and pencil versus computer-based tasks. But really, when we're thinking about the types themselves, there are a few key considerations. So there are what are considered the restorative approaches, and this is with the drill and practice idea. So going back to the earlier slide, if we think that there are inefficiencies between in some of those cognitive processes, then essentially this notion that if we can have cognitive drills, a kind of a brain gym type of approach, that if we could improve those processes, it could have a knock-on effect on that. These have particularly been used for some of the low-level perceptual processing, as well as targeting things like attention and memory itself. And so there was a whole approach towards using it, for instance, with simple auditory processing. So just being able to differentiate between tones and simple visual processing components, because the idea was that it's also possible that the initial data that is coming into the brain is degraded because of poor perceptual processing. And so if we could kind of clean up that signal, that might make it easier to function. So, the difference between, for instance, seeing through clear glasses, which are appropriate to your power, versus like glasses which are muddy or murky or don't have the right power, it's a lot harder to actually see, perceive, and therefore process all the stuff that's happening in the world around. But there are also other approaches which have then tried to use the same approach for higher level, more executive functioning and so on. But as some of you may know from the data that had come out with like Lumosity, just this repetitive drill and practice approach, there have been some findings which have shown that it has been helpful with really basic perceptual processing, and there was some data that found that it is helpful with improving performance on the task itself. So for instance, if I'm doing a working memory task of the type that I showed you earlier, if I did that a bunch, I would get better at that task, but it wasn't actually generalizing out. There are also the compensatory strategies, which are essentially finding ways to work around some of those cognitive problems themselves. And so learning new habits, finding strategies that people can use to mitigate the effects of that. And these compensatory strategies could be cognitive strategies that they're using, for instance, like I'm going to start carrying a notebook around and make notes or set reminders for myself. There were also approaches like one which is referred to as cognitive adaptation training, which is where we modify the person's environment or where they live. So we want to have like Post-its at important places, or find ways to sort of arrange like someone might kind of arrange the fridge or like leave little cues in the house as reminders for what the person might need to do, just to try to kind of get them going and kind of find ways to navigate around the difficulties that they have. And then there are approaches, so cognitive remediation style approaches, which are focused very much on social cognition. So improving emotion recognition, working with people with social skills groups to help to improve the recognition and the use of appropriate social cues and so on. And typically, these cognitive remediation programs are fairly intensive. So some programs are 2 to 5 days per week. And some of them have been short, and some of them have been a lot longer, so up to a year have been studied. But what we find is that it is, of course, helpful to have people learn these skills and to find ways to practice them. And the different the different groups or different studies have used both individual and group formats or a mixture of those two, and more often within the context of a wider rehabilitation program. What we find is that when people have just used those computer skills, or they tend not to generalize. And of course, the use of the compensatory strategies can be really helpful. But when we think about a full cognitive rehabilitation or cognitive remediation package, we want to try to combine the best of those. So there was, again, a recent white paper that had come out from Chris Bowie and colleagues, and they talked about what are the components of cognitive remediation. And they suggested that there have to be these 4 components for something to be considered a full CR package. And one of them is that there are therapists which are assisting in the treatment, because the data has consistently found that non-therapist assisted programs do not generalize, and that was the problem with Lumosity, for instance. And so the therapists and the participants understand together what are the specific cognitive challenges that the person is struggling with. They formulate the cognitive problems, how they play out in their daily life, and link those difficulties to the goals that they have. There are the cognitive exercises that people are working on. So this is with the goal of the restorative approaches. We assume that they help with increasing neuroplasticity. And more commonly, we tend to use the computer programs. There are paper and pencil versions, but most of the CR programs now tend to use these computer packages. And the packages typically work either with errorless learning or with setting a particular difficulty level. But the goal is that participants are constantly being challenged, and as they are getting better, the complexity or the difficulty level is being ratcheted up so that they can feel like they are constantly pushing themselves. And while they're doing that, the really important part is not just the rote engagement with the task, but rather to also identify and monitor strategies that can be used while they're doing those tasks. And this is something that is facilitated in discussions with the therapist as well. And then the 4th component is facilitating transfer to the real world itself. So that participants can set their goals and to have reasonable expectations for what that change might look like, to highlight the strategies that have been helpful in the tasks that they were doing, and how they might apply those to their activities in daily life, and to really focus very explicitly on the transfer techniques. So, thinking about either the use of near transfer tasks in session, or potentially role plays, the discussions of how they might do things, and so on. So the way we had been running it has been as a group, and typically there are like multiple sessions per week, which can be between 1 and 2 hours per session to teach the material. And how we've done it is essentially we have a discussion of what is the cognitive domain, what are some of the difficulties that people experience. They have the discussion about, for each of them, how this may play out in their daily life. They start to work on the computer task. Then we have a discussion about what are some of the strategies that they're noticing that they're using, what are some of the difficulties that are coming up in the task itself. We also highlight and brainstorm different strategies that different people have been using. They then return to doing the same computer tasks again to see if they're able to incorporate those strategies in while they practice. And then they go home and try some of those in between sessions as well. And then finally, towards the end of the group, we also have a separate part where they talk about how they may be able to generalize those strategies to their daily lives, or use those strategies around specific tasks that they're going to be working on over the next few days or the week itself. And the computer programs, there are a few of them which are widely used. So there's one that we've used a lot, which is called Happy Neuron or Scientific Brain Training Pro. There's another one called CogPack. There's another one from a company called Posit Science. And they all really cover the spectrum of cognitive domains, so attention, processing speed, working memory, verbal and nonverbal memory, visuospatial functioning, the different domains of executive functioning, and so on. And so in our groups, they had used the software to train those different domains, and the programs are all typically available as online programs, so the person can log in, they're set up with an account, and they can do that in session, and then also log in at home to practice it. And the therapist can actually track how they're doing, what are the levels of difficulty that they're reaching. And these are, they're not particularly processor intensive, so they can be done even on an older computer. They can also be done on a tablet or like an iPad. And as we said, the difficulty levels for the tasks are adaptive and just keep getting harder or more challenging as the person progresses. So I thought I might just show you a couple of different examples. These are from the very simple end of it. So these are, this is sort of a selective attention task. So this one is, for instance, an odd man out. You are shown a set of pictures, and as quickly as possible, you have to try to identify which one was the odd man out there. So in this case, it's the one in the second row on the left-hand side. As people are working through those, the targets and the distractors get much more challenging, and they have to try to do it in a shorter and shorter period of time. This is an example of one of the verbal memory tasks, which is that you have to try to remember the words which are on this list. This is, of course, not this is not one of the starting levels. This is one of the harder ones, and then they're shown a list of words, and you have to identify the two other words. There's a different version of this task, which is, for instance, that you're a server at a restaurant, and then there are either 2 people at a table, or 3 people at a table, or 4 people at a table, and they might order like 1 course, 2 courses, 3 courses, and then you have to actually sort of take the food back and kind of give it to the person on each of those tables in the right order as well. So something which can be meaningful or have some translation, but really also trying to find ways to associate that information with particular people, and thinking about what are the strategies that the participants are using to ensure that they are that their accuracy is improving over the rounds as well. This is a common task which is used as an executive functioning task. It's sometimes referred to as the Towers of Hanoi or the Towers of London task, and you're shown a configuration. So at the top, you can see that that stack on the right-hand side, and this is the configuration that people start from, and they would kind of click and drag the little rings from one to the other, and the rule is that you can't have a larger ring over a smaller ring. So for instance, you couldn't move the blue one in the middle over to the one on the left. So you have to find the way to move these across from one to the other to achieve that configuration on the right hand side in the fewest number of moves. So this is the usual CR program. The training workshop that is going to happen is an approach to CRT that's called action-based cognitive remediation, or ABCR, which was developed by Professor Chris Bowie. And ABCR combines the cognitive training with in-session near transfer tasks which can simulate a work environment or other daily challenges. So for example, you may have like a shop environment where participants have to switch between different tasks that they need to do. So filing receipts and orders that need to be sent out versus sorting out objects, and they have to kind of switch between these different ones. That would be an example of an executive functioning task where you're having to carry out something for a while and then stop and switch between one and the other to make sure that you're doing enough of both in a fixed period of time. Or it might be a shopping list where you would have to actually like go through and then actually pick different things or put them back in the right order. There is one which is where you're taking a voicemail from a friend and then figuring out what would be the shopping list that you would need to make for them given their own preferences and dietary restrictions and so on. And so the sessions there would typically include doing the computer tasks that we talked about and the discussion of strategies. And then there are actually these props which are provided as part of the ABCR package itself that would then allow folks to work on these near transfer tasks in sessions. So we're creating a simulated environment which might hopefully then help with being better able to utilize these tasks in daily life. So ABCR is relatively new. They've had a few recent studies which have come out, which have actually found really positive effects. And we think that these might actually have an effect that could be even larger than the standard effect that we see for CR itself. The field is still, as you can imagine, developing and growing, and there were a few meta-analyses that had come out from a few years ago. So a meta-analysis is where you look at all the studies which have been published and look at what are the what we call the effect sizes. So the differences between the averages, the average performance for the patient group and the control group. So the group that did the CR versus the group that didn't do the CR in this particular case, and look to see if the averages across all of the studies were statistically significant. And so this is a meta-analysis from quite a few years ago now, which was with 26 studies. There's been a more recent one which has had it with about 40 odd studies. And essentially what we find is an effect size of about 0.4, which is statistical speak for saying that it is a medium effect size and that it is statistically significant and has been shown to be helpful. So the meta-analyses and the reviews consistently indicate that they work, and particularly they work best when they're part of a larger psychosocial rehab program itself. And so the second part of the talk is going to be Dr. Amy Burns, and she's going to be talking about a very interesting study that they've run where they were combining this with IPS. And so I want to acknowledge all the folks who've been involved with this Cognitive Remediation BC, this working group that has been developed, which has some of the people who are on this call, a number of people from PSR Canada. I want to particularly thank Amy Burns and Tom Eamon, and the folks from PSR Canada, Regina Casey, Manny Chen, Vicky Hoon, as well as my collaborator Todd Woodward in our lab. On our lab page, which is the Cognitive Neuroscience of Schizophrenia lab, or the CNOS lab, we have a CRT page, which has a lot of information about CRT, some of the things that we talked about, and we're going to be putting up some videos as well in the near future. And we're going to also put that information up on this other page, which is cognitive-remediation.ca. That on that page right now is just a link over to the registration for the conference. But once that's done and we have some time, we'll actually transfer more information about CRT and some of the content from our lab page right now across. So that's it. And thank you very much.
All right. So I'm going to be talking about a cognitive remediation project that was a partnership between the BC government and the Canadian Mental Health Association, and also with Fraser Health and Vancouver Coastal Health. So this was a, can you hear me okay?
Yeah.
Hi, can everybody hear me?
Yes, we can hear you.
Okay.
You seem to have
Um,
lost your slides right now, though.
okay. So this was a 36-month project that examined whether we can improve work outcomes and cognitive functioning in clients with serious mental illness. And before I get to the our study, I just wanted to give some background about why do we focus on work? Why do we target work outcomes in our study?
Amy, the slides have gone off, so we're just seeing you now. So.
Oh. Okay. So let me see if I can share that again.
Yeah, and we can see the slides now.
Okay, so I will start. Okay. So I was saying about why we focus on work in our study. That's partly because many people with serious mental illness want to work. Work provides clients with a sense of purpose, and many clients often describe work as an important part of their recovery. Furthermore, work is associated with a range of benefits, including increased self-esteem. And it also leads to better economic standing, and also increases satisfaction with finances. And it also can improve a sense of recovery, having a routine, working again, and it can also reduce utilization of mental health. So those are some of the benefits that come about as a result of working. And despite the interest in work, rates of competitive employment for clients with schizophrenia are quite low. They range anywhere from between 10 to 20%. And for clients who want to work, help is available. There's a program called Individual Placement Support, or IPS for short. And IPS is an evidence-based method of getting clients back to work. The first principle IPS that every person with severe mental illness who wants to work is eligible for IPS supported employment. What this means is that it's very low barrier. There are no exclusionary criteria. As long as clients express an interest in work, they're eligible for the. The second principle of IPS is that employment services are integrated with mental health treatment. So IPS are part of the mental health team, and they share offices with clinicians, and they are part of the client treatment team. And that's really important for integrating services for clients. The third principle of IPS is that competitive employment is the goal. So the focus is helping clients with employment. If clients are interested in volunteering or returning to work, then they would be referred to a different program altogether. And because IPS is only focused on competitive employment. Clients are also provided with personalized benefits to help them understand what are some of the consequences of returning to work? What are some of the benefits of returning to work? And the job search, as soon as the person is expressed interest in work, what this means is there's no pre-employment with IPS services. Clients work as soon as they express. And then employment specialists then develop this work with the employer and also the client based on the client's preference. Another principle is that job supports are continuous. So within Fraser Health, clients can receive services up to a year and sometimes beyond if necessary. And once a client obtains employment and are working, job work doesn't stop there. The IPS work continues to help support the client to help them maintain the job, not just to get a job. And then the last principle is that client preferences are honored. What that means is that the client's preferences for the number of hours they want to work, whether clients want to work part-time or full-time or casual work, that preference is honored. Other preferences may include where they want to work or what type of job they want. So the IPS workers work closely with clients to figure out what is it that clients would like out of work, and working towards trying to match client preferences to the job that they would like to do. So there have been several meta-analyses that have examined the effectiveness of IPS. And as Dr. Menon mentioned earlier, meta-analysis is just an average of effect sizes of different studies. And overall, the success rate of IPS is around 50%, which is quite robust if you think about mental health service treatment. That approximately half the clients who enrolled in IPS services go on to find competitive employment. However, that also leads us to ask the question, well, what happens to the other half of the clients who are not successful with IPS? What happens to the other 50%? And so that leads us to our research question of, can we add cognitive remediation for clients who have not been successful with IPS? And will that lead to improved employment outcomes? So here are our hypotheses. So our null hypothesis is that CRT added to IPS makes no difference. Our alternate hypothesis is that adding CRT will improve the percentage of clients who obtain employment compared to IPS. And we also hypothesize that this also leads to more hours of work for clients. And our third hypothesis is that CRT trading will also lead to improve cognitive scores over clients in the IPS services alone. So the program we use is called Thinking Skills for Work program. It was developed by Susan McGurk and Kim User out of Boston University. And the program has 3 components. The first is the computer cognitive training. So the computer cognitive training is the restorative drill and practice that Dr. Menon mentioned earlier in his talk. The second component of the program is the teaching of coping strategies. So this is the compensatory strategies. This is helping clients learn workaround strategies to bypass the cognitive difficulties that they may experience. So the program is also administered with supportive employment or IPS. And the Thinking Skills Work program consists of, like I mentioned, the computer cognitive training and the individual sessions. So there are 12 individual sessions. And each session has different, so this is a list of the topics that are in the session. So the first session, we focus on understanding the cognitive skills and how they're related to work. So as Dr. Menon mentioned earlier, if you're having difficulties processing information, that may translate to difficulties with work. To help clients understand the relationship between some of the thinking skills and how they may relate. We also look at recognizing client strengths. In addition to not just the cognitive challenges they're having, but what are some of their strengths? And in session 3, we focus also on challenging clients' negative thinking. So these are our clients that are in the program have been with IPS services for a minimum of 3 months. And if they haven't found a job, they get referred to our program. So some of the clients who enter the program may be starting to feel discouraged about their prospect of work, or they may start to feel that they may never get a job. So we want to challenge some of that negative thinking associated with their challenge the negative thinking associated with how they perceive their progress in IPS services. The next two sessions, we focus on workaround strategies to deal with attention and concentration difficulties. And then we also discuss strategies with memory difficulties. And then the next two sessions, we focus on this transfer to real-world functioning. So we're looking at cognitive adaptation in terms of developing routines for job search if clients have not found a job yet, and also developing routines at home as well. So once clients obtain employment, how might that change their routines at home? And so looking ahead and planning ahead and helping clients prepare their routines so that they can be successful once they start. We also have sessions devoted to how to improve thinking speed. We also talk about strategies with planning ahead. So with either benefits planning or with setting up routine, or we can also talk about problem solving. Once clients start working, are there any anticipated problems that client may see happening? And then we work through examples of potential problems that might arise, and then we help clients try to solve some of those problems. And the last session is just a wrap-up session reviewing all of the strategies we've talked about. And so those sessions are delivered in an individual format. So the next component is the computer cognitive training. For this program, the Thinking Skills for Work program, we use CogPack, and CogPack consists of 64 test and training programs, and they target very similar domains as what Dr. Menon mentioned earlier with brain training pro or SBT Pro. So CogPack focuses on visual motor skills, training on in attention, language, memory, problem solving, and everyday skills. The tasks are customizable to client cognitive profiles. And within the Thinking Skills for Work program, we ask clients to practice 2 sessions a week in addition to the individual training that they do with the cognitive specialist. So the program consists of individual weekly sessions and then 2 sessions of computer training at home on a computer. Here's an example of an attention and concentration task. So this task tests perception of figure and background and client scanning speed. So it trains selective attention and perception of forms and objects. The clients are asked to find the hidden number on the screen. So here's a hidden number. So that's the Training for Work program itself. Next, talk about recruitment. So our study originally, Fraser Health had IPS services at 6 mental health. The project expanded services to an additional 4 sites to increase the pool of clients to which we could recruit from. So we started recruitment in Burnaby, Tri-Cities, New West, Surrey, Delta, Langley, Maple Ridge, Mission, Abbotsford, and Chilliwack. The reason that we had expanded recruitment to begin with, we're only targeting half of the clients in IPS because we know that half of the clients are very, they don't need the service. They do quite well with finding employment without this particular service. So it's only the 50% of clients who look like they may not be successful with IPS that we are targeting. So it does limit the number of clients we can recruit. And so we started with 10 centers, and halfway through the project, we recognized that we weren't going to meet our recruitment target. So we expanded our service to 4 sites within Vancouver Coastal Health. So we added in Kitsilano, the South team, Ravensong, and the Northeast team. So here is our consort diagram. So this is the flow chart for our study. So we received a total of 125 referrals, and we assessed for eligibility. We tried to follow the IPS principles and had very little exclusionary criteria. Our only exclusionary criteria is that clients could not have had a head injury or a loss of consciousness for more than 5 minutes, because that may lead to difficulties with learning new information. So how we recruited our clients was that clients were asked by their IPS peers if they would be interested in participating in the study. Then our research team contacted the client and explained the study a bit more. And once they got more information, 18 clients declined to participate. And then the other reason, I believe that was the one client who found out she was pregnant when she started the program, and she wasn't actively job searching. So she was not eligible for the study since she wasn't actively looking for work. So then we completed baselines on 97 clients, and we randomized 47 to the treatment as usual. So this in this group, clients continue to act as IPS services as normal, and another 50 clients were allocated to cognitive remediation. So clients in this group were asked to continue to meet with their IPS worker as usual, in addition to attending the individual session, weekly session for cognitive remediation, and also the computer training at home. And at the 3-month mark, we completed 42 assessments in the treatment as usual group. We had one client move out of the country, and then we lost 4 to follow-up. Similarly, in the cognitive remediation group, we completed assessment on 48 clients. We lost 2 clients to follow-up. And at the 3-month mark, we had 42 clients completed 6 or more cognitive remediation training sessions. And then at the 9-month follow-up, we had pretty low attrition rate overall. We only lost 1 client to follow-up after 6 months. And then in the treatment group, we had lost 2 to follow-up, and then 1 client withdrew from the study. So overall, we had pretty good retention rate for the study from when we started at baseline, and then 3 months of follow-up, and then 6 months follow-up after that, so 9 months overall follow-up. So here here's the demographics for our group. Overall, the mean age of our group was 40 years old, and on average, they had 13 years of education. In terms of symptom profile, there were no significant differences between our 2 groups in terms of age, education, or symptom profile. So our randomization worked. The only thing was that there was slightly more male in our IPS only group compared to our thinking skills group work. In terms of group composition, we had only 18% of the clients in the group had a diagnosis of schizophrenia. 20% of clients had a diagnosis of schizoaffective disorder. 30% of clients had bipolar disorder. Approximately 20% of clients had major depressive disorder, and then 9% had another diagnosis. In terms of CRT training, this is our average attendance. So on average, clients completed 10 out of 12 individual training sessions. So for an average of around 83% average attendance, which is good. In terms of computer training, we had lower completion rate. On average, clients completed 12 out of 24 of the computerized training sessions. So the computer training session completion rate wasn't as high as we would have liked. It's actually a bit lower than what we would have liked. So in terms of our outcome, we had hypothesized that CRT will improve employment for our training group. So we did a repeated measures analysis, and what we saw was that there's an effect of time. What that means is that both groups improved over time. As you can tell, TRT is the blue line and the IPS only is the red line. And at baseline, clients in the TRT group, 19% of them were employed compared to 13%. So that's not a significant difference. But at the 3-month mark after training, that's where we start to see the divergence between the two groups. So the CRT group, 52% of clients were currently working compared to 28% in the IPS only group. And then this difference is maintained at the 9-month mark, where we see around 60% of clients in the CRT training were employed compared to 34% in the IPS only group. So there's also a time by condition interaction effect. And so when we break down the interaction effect, what we find is that the difference is driven by different 3-month and at 9 months, and not at late. With regards to our second hypothesis that CRT training will lead to more hours worked, we see a very similar pattern. Baseline, there's no significant differences between the two groups in terms of number of hours worked. They were 3 and 2 respectively. And then at the 3-month mark, we see that the clients in the CRT group worked on average 13 hours compared to 7 hours in the IPS only group. It wasn't a significant difference though when we broke down our interaction, but we do see a significant difference at the 9-month mark, where clients in the CRT training program worked on average 21 hours per week compared to 10 hours in our IPS only group. In terms of cognitive scores, cognition was measured using the matrix consensus cognitive battery. So the MCCB is a standardized battery backed by National Institute of Mental Health, and it's intended to provide a relatively brief measure of key cognitive domains that are relevant to schizophrenia and related disorders. The battery is appropriate for use as an outcome measure for clinical trials that was designed for clinical trials of cognition enhancing drugs. And it also can be used for studying cognitive remediation to measure cognitive changes over time. So the MCCB subsets are on the x-axis. Those are the different tests that make up the MCCB battery, and on the y-axis is the T-score. So T-score has a mean of 50 and a standard deviation of 10. So think about, on average, people in the normal population would have T-scores around 50. So at time 1, this is data for our cognitive remediation group. At time 1, we see that clients perform 1 to 1.5 standard deviations below the mean, which is consistent with other research studies, and it's also consistent with the studies that Dr. Menon presented earlier, where we see a client with psychosis or schizophrenia score significantly below the normal mean. And so at baseline, they look comparable to what we see in the literature. What happens at time 2, after they've completed the thinking skills for work training program? How did they do then? So not a lot of changes that we see. We did see some improvements on the Wexler memory scale, the spatial span. This is a test of nonverbal working memory. And we also see changes in the brief visual spatial memory task, which taps into visual learning. However, these differences were no longer significant once we took into account multiple comparisons. Because we have 10 domains across, we have to correct the number of times that we do these hypothesis tests. But so no significant differences from time 1 and time 2 for our cognitive remediation group. For our IPS only group, we see a very similar pattern. That is, at time 1, there's clients are scoring 1 to 1.5 standard deviations below the mean, and at time 2, we see improvement, but these are not significant once we take into account multiple components. So what we do see is that overall there's a significant effect of time, which means what that means that both groups improved over time. And this is an artifact of what we call practice effects. So practice effect occurs when participants become better at performing tasks if you ask them to do it a second time. So we see a significant time effect, but we don't see any time by condition. So overall, conclusions for our study. So we see that CRT improves work outcomes for clients who have not found success with IPS. The improvements in terms of the percentage of clients obtaining competitive employment and the number of hours worked was quite impressive in terms of the improvement seen in the CRT group. However, we didn't see any improvements on cognitive scores, and that could be for a number of reasons. I've mentioned the practice effect makes it harder to identify differences between the groups, and also perhaps the cognitive measure that we're using, the MCCB, not a sensitive measure to pick up on changes over time. But it could also be an artifact of the fact that our adherence to computer training was quite low. So on average, clients completed only 50% of the computer training. So perhaps the dosing for computer training wasn't enough for us to pick up or detect these the differences with the MCCB battery. Overall, we had pretty good attendance for the individual sessions. So 83% of clients completed 10 out of 12 sessions. And so we see improvements in the functional competence, and clients are returning to work. They're improving the community functioning piece, but we're not seeing the changes in neurocognition as measured by the cognitive scores or the MCCB that we use. So, and I want to say special thanks to all of our participants who made this research possible. We would not be able to do this without their participation. So we're grateful for all the time that our participants put into completing the assessments and doing the training as well. Also thanks to Dr. Dave Erson, the PI on the project, our research assistants who did all the pre and post assessments, Lisa Casagrande, Gabriel Book, Ejin Kim, and also Samar Hijazi. She's our statistician consultant with Fraser. Thank you. That's it for me.
Thank you, Amy. If anyone has any questions, now is the time. Oh, we've got a couple here. What do you think was the reason for poor participation in the group sessions?
Oh, for the computer training?
Sure.
So, yes, so overall we had pretty good attendance for the individual sessions. The clients attended on average 10 out of 12 sessions. It was the computer training that clients didn't complete as much of. Cognitive is an older program compared to some of the newer programs that are out there. It's not as visually pleasing as what Dr. Menon showed you with some of the newer programs. But overall, clients, there was various reasons clients didn't participate in the computer training. Some clients reported that if they were currently working, they didn't have time to do the additional training at home in addition to attending sessions. So they prioritize attending sessions, individual sessions, over doing the computer homework if time was an issue for the client.
Thank you. There's another question. Do you think this program works with highly functioning and educated persons with mental health diagnosis who also experience problems in memory and focus? If not, are there other programs out there?
Oh, yes, definitely. So our clients, we recruited clients out of the mental health team. They're outpatients. Some of them are quite high functioning. Again, we didn't have a lot of exclusionary criteria in terms of meeting a certain benchmark to be enrolled in the program. We accepted all clients that were referred to us. As I mentioned, the only exclusion criteria is that not having a head injury and losing consciousness for a minimum of 5 minutes.
Thank you. Pardon me if I'm missing any questions, and there's a lot of comments here. So if you have any more questions that haven't been addressed, please type them in, and we will get to them. So there was one, is the IPS program still active? And if so, is there a referral process?
Yes, so the IPS program is available through the outpatient mental health at Fraser Health and at Vancouver Coast Health. Clients, as I mentioned, it's a low barrier program. So if clients are with the mental health team and they express an interest in work, they let their primary clinicians know, and then they refer them to the IPS program. So our project brought funding for an additional 4 sites within Fraser Health. As I mentioned, we expanded service to Mission, Langley, Abbotsford, and Chilliwack. Now that the project has ended, the IPS services is not available in some of those sites, but because there was such a demand for IPS services that we were able to find funding to continue IPS services in Abbotsford and Mission. So as a result of the study, Mission and Abbotsford will now have regular IPS service within Fraser Health. But all the other IPS program within Fraser Health, they're still running.
Thank you. Okay, there's a long one here. I'll read it. I don't know if you can see it as well, Amy. So excellent results in supporting IPS with CR, but it looks like not many people with schizophrenia were included. There seems to be robust interest from funders in using CR to improve chances for competitive employment. Do you see this level of interest in helping the many people who need CR related help to managing the daily tasks of daily living? Do we need additional research on using CR with the population for whom competitive employment isn't the goal? There is a lot of interest in reducing the high rate of relapses in people with schizophrenia. Do you think that CR could help reduce relapses because it could help people manage daily living tasks like managing medication and attending appointments? There seems to be robust interest from funders in using CR to improve chances for competitive employment. Do you see this level of interest in helping many people who need CR-related help in managing daily tasks of daily living?
So those are good questions. So our funder, we were funded by the BC Ministry of Social Development and Poverty Reduction. So you're right that there was an interest in helping clients with competitive employment to improve poverty reduction. So yes, that was the focus of our funder. But I also see, and the other question was related to the group composition, and that there weren't a lot of clients with schizophrenia in the group. So as we mentioned, we try to follow IPS principles and try to have as few exclusionary criteria as possible. So we do not rule out substance use. We do not rule out you need to have a certain diagnosis to be enrolled in the program, because IPS service is very inclusive. And so we wanted to follow that principle as well. And so what we saw, the breakdown, is what you typically see in an outpatient mental health center, where you see a third of clients have schizophrenia or schizoaffective disorder, another third having bipolar disorder, and then another third of a catch-all major depressive disorder and anxiety disorder. So overall, the clients that we saw, the population, it's pretty typical of what you typically see in an outpatient mental health center.
Good.
So there's a lot of questions.
Thank you. Yeah, there's a lot. So I have a question, actually. So back to the employment piece. If we perceive that someone isn't employment ready and maybe we don't think that it's in their near future, do you see that cognitive remediation will support them to like be able to achieve something that maybe we don't think that they can, but applying this could give them an outcome that we didn't see before? Have you seen anything like that?
Yeah, so we've had some clients that were referred to the program, and again, because we have very few exclusionary criteria, clients can still have active symptoms and still want to work, and they would be accepted into the program. So we've had a couple of clients who wanted to express an interest in work, but they were actively having hallucinations. They're still responding to their hallucinations. So in the training, in the individual training, we talked about some of the strategies that can help clients during an interview. So preparing for interviews, planning ahead, looking at different routines. We looked at planning for job searches, and then when you plan for job searches, you also plan for interview. So when clients go into an interview, what are some of the expectations that employers may have? We did some practice on answering questions during interview, and we also looked at some coping skills with how to handle some of the voices to reduce the distress that clients can experience during an interview as well. So even though some of the clinicians thought the client was not ready to go back to work because of active symptoms, the client expressed that they were interested in work. We worked with the client to minimize the stress and the disruption that the symptoms cause, to help clients go for job interviews, apply for work, just like any other clients. And I think that's important that we honor clients' preference and respect that if clients want to work, then we can help them and not judge that we think clients are not ready based on symptoms they're having. If they think they're ready, we're there to help them.
I think also the flip side of that is that the Amy study was trying to add IPS to the CR program, but typically it has also been done in other contexts, so outside of the work context as well, just where there is where essentially we're trying to help with improving their ability to function in the community or live more independently and so on. And what the data suggests is that if we can do those multiple components of the CR, essentially sort of thinking about in addition to the exercises which could potentially improve cognition, also work on strategy utilization, strategy generalization, and just thinking about their applications in different contexts, that those would be helpful even, for instance, with someone who is looking to live more independently or improve their social functioning. And so there have been attempts to combine CR with social skills training to see if that would help people just function more independently in whatever those roles might be.
Thank you. Here's another question. Sorry if I missed it. I'm curious if Dr. Menon found any similar barriers to clients completing the between session practice in his program.
Yeah, so we've run our program in a couple of different contexts. So I work on the BC psychosis program, which is an inpatient tertiary unit. So many of our clients on the program here do have fairly significant and persistent symptoms of psychosis. That's why they are in our program. And so I think there we certainly have difficulties with our clients kind of engaging with the tasks between sessions. And so we often work with the rest of the team or try to sit with people one-on-one to try to get them to do those tasks in between. We also run this as part of a study with clients from mental health teams or who are outpatients. And there we really find that how much people do the tasks, the computer program in between sessions, is really contingent on a couple of different factors. I think one is, are people feeling motivated to work on their cognition, so their own awareness or desire to work on those skills? And the second part is how comfortable they are with computers and the access to it. And we found that for people who say, yes, I notice that I have, oftentimes, like I said, people would say that they have memory issues. So they say, yes, I notice I'm having these memory problems, and I do want to work on those memory problems, and they're comfortable with computers, then they were more willing to engage with it. So again, I think like it's oftentimes easier if we can get people earlier in their illness, because younger people do tend to be much more comfortable. But yeah, I think for a lot of people with any of our therapies, so to speak, lots of times we have to find ways to have the client themselves be motivated towards the therapy, because lots of times well-meaning care providers, family members, they want the person to engage with therapy, but if they don't really want to, we have a fairly minimal level of engagement, unfortunately.
Thank you. Here is another question. I'd like to see a study using using the leisure to improve cognitive function. So they are asking why funding is often directed towards employment. Is there any plans for a study that's more kind of leisure, or like the other commenter said, daily tasks of daily living? Is there any plans for a study around that?
I think our studies had been really more looking at the effectiveness of CR on functioning, on both the on whether it actually improves cognition or improves social functioning. Those were the outcome measures that we were looking at, and we were actually another CBT-based group therapy intervention. So I think that, of course, the more engaged people are with any kind of leisure activity, particularly social leisure activities, those are going to be net positive. So I think that the data, and outside of psychosis, the data with healthy aging actually suggests that being engaged with leisure activities is a really strong predictor of increased independence, improved cognition, and preventing age-related declines as well. So we do recognize that they are important. They just haven't been the focus of kind of what we've been looking at, mostly just related to Amy's and my research interests and our training itself.
Thank you. Thank you. One more question. Someone is asking if we are able to distribute a list of places where these programs are offered. Is that
so
something?
I think part of the reason why we are keen to have the workshop is because CR is not widely available within the mental health teams across most places. So I'm only familiar with its availability around the lower mainland, and it's been fairly minimal. We used to have a group that was running for a while, but it was funded by a grant that we had, and we ran out of our grant last year, so we had to wrap up the groups. There is some CR which is being run through the VCH, the Vancouver Early Psychosis Intervention Program, and then Amy's group has some CR opportunities in the Valley that she could comment on, but it's really minimal otherwise. And so our hope is that with this workshop, we're hoping to have clinicians from across BC that would come in, and then the goal would be to try to roll this out across the province over the next few months.
So last question. I know more are coming in, but before we close at noon, can you tell us a little bit more detail about the upcoming workshop happening in April? Tell us what people will learn, when it is, how much it costs, where they can register and all that. And if people want to stay a little later than noon, we can answer some more questions if you're able to.
Sure, yeah. So the workshop is, I think it's at the 28th, 29th, and 30th of April. It's the Tuesday, Wednesday, Thursday in that last week of April. It's Professor Chris Bowie, who I've mentioned multiple times. So he is a professor at Queen's University and really one of the world experts on cognitive remediation. So the 3-day workshop will basically be focused around the action-based cognitive remediation that I talked about, that they had developed. And so it would allow clinicians to have an understanding of the materials, what would be the strategies that they want to use and highlight, how would they be using the computer program, as well as the transfer tasks, and would allow them to sort of just have all the training that's needed in order to be able to go back and start the groups in their home community. We're assuming mostly with like community mental health teams, and the workshop I think is $495 per person for the 3 days, and what they would need in addition to actually doing the workshop would be to be able to have you have to subscribe to those the programs which have varying amounts. So the subscription that we have, it works out to a little bit over $100 US per month, and those are site subscriptions. So for instance, on our site at the UBC hospital, all the patients who are using it here would have access to the program through our site license, and they can continue to use it for as long as they would like. And so you would need to get that. You need to get either some computers or tablets that could be used to run the program. And then you could buy the transfer task materials and the manuals directly from Dr. Bowie's group.
And I think what's really exciting about the training is, after the training, what we're hoping to do is to have ongoing supervision. So the Cognitive Remediation BC working group, we're working towards developing an advanced practice to support clinicians who want to implement CR in their clinic and to be able to deliver it according to fidelity with ongoing supervision. So I think that's a really exciting component of the workshop.
Excellent, thank you. So there is a link in the chat to where you can learn more about the conference and register. I think it's very exciting that this is happening, and I encourage you to talk to your teams about it and try to find some people who you think would like to attend. It's an amazing opportunity that doesn't always come along. It's kind of, it's kind of the first time we've been able to offer this. So I would encourage you to try to figure out how to get there if it's something that really interests you. So the link is right there. I realize we are at noon. There's a couple more things that came in. So if you have to go, I understand that you have to go, but we'll keep plugging away. So there is one more question about references. If you're able to cite or share references that you cited in the presentation. And we can always post the slides and anything like that on our website that people can access later. And here's another question. I'm working at a community mental health agency, providing group and individual programs to help our clients integrate into their communities, find leisure, resources, employment, etc. Is there a way we could integrate some of the program done in the study into our daily practice? I mean, are there resources for the teaching coping strategy workshops, for example, or do you have to use the whole program? I don't know if that's what she's asking. But.
So there are other approaches which are just focused around the compensatory strategies part of it itself, which is, one component of what we would think of as the full CR package. So there are, I know that in Vancouver, and the OT group has tended to use an approach which is called smart brains. There's also an approach which is called CAT, or cognitive adaptation training, which is about ways to sort of modify the environment and to use strategies to work around people's either disorganization or initiation difficulties. And the person who has developed that is a psychologist named Don Valigan out of Texas. So there is a CAT treatment manual which is available as well through them. And there are other just essentially like compensatory strategy parts which can be used just as is. What we have been trying to think about is what would be the ways to roll out what we think of as the gold standard CR approach. And our hope is that we would be having the training here in Vancouver. The training is actually going to be on the UBC campus itself. And if people are coming from out of town, there are, I think there are like places to stay on campus as well for the workshop. But the hope is that we would have people from across BC come and do the program, go back to their communities, and as Amy was mentioning, to then be able to join in around the supervision and the consultation piece with Dr. Bui in the months after the workshop, so that we can make sure that it's being rolled out with fidelity to the model, and for people who are really interested in it, they can get certified as a CR clinician itself.
Thank you. Great. Thank you everyone for attending. It's been a great session. We hope to see some of you out at the training in April. Have a fabulous day, and thank you for presenting. This was a fabulous webinar. I learned a lot, and I appreciate you taking the time to be with us today. Thank you.
Thanks.
Thank you.